area is on breast imaging and risk prediction models.
Hi, I'm Julia. I'm trained as a scientific researcher, and I looked at pregnancy, lactation, and breastfeeding outcomes. Right now, I work in communication strategy and information design, helping people turn scientific ideas into real-world impact.
Thank you. All right, so Dr. Arleo, do you want to share your screen and kind of start with your presentation? And then we'll jump into some questions at the end. Thank you.
Are you seeing just my slides?
Yes, we are.
So thank you again, Kendra and Medara, for this opportunity to speak, and it's a pleasure to meet my co-panelists. For the purposes of this talk, again, I'm going to be speaking from the perspective of a breast imager, and in the next 8 to 10 minutes, my aim is to provide a brief overview of breast cancer risk prediction, focusing on where we are currently, the strengths and limitations of traditional risk models, and how imaging biomarkers and AI are beginning to reshape risk assessment. And I would say, as breast imagers, I think we're uniquely positioned because we not only detect cancer, but also increasingly hopefully contribute to predicting who is most likely to develop it. I'm trying to advance my slide. So this is my disclosure slide. Again, clinical imaging, we do have a dedicated breast imaging section if you're looking for an excellent review for your work. So why does risk prediction matter? Well, breast cancer screening has historically been based largely on age, with a well-established data-driven ACR recommendation for women of average risk of annual screening mammography, starting at age 40 and continuing for as long as a woman is in good health. However, we know that breast cancer risk varies substantially among individuals. Some women are, in fact, just at average risk, while others have several-fold higher risk due to genetic, clinical, and pathology factors. So accurate risk prediction enables more personalized screening strategies, identifies candidates for supplemental imaging or preventive interventions, and really helps direct healthcare resources more effectively, which we have to think about in this day and age. The ultimate goal, obviously, is to move from a one-size-fits-all approach to a truly individualized breast cancer prevention and early detection. So there are several risk prediction models that are currently used in clinical practice, including the Yale model, also known as the Breast Cancer Risk Assessment Tool, which incorporates age, reproductive history, prior biopsies, and limited family history. And the Gale, I'm always interested in where these names come from. The Gale and the Gale model refers to Dr. Mitchell Gale, a scientist emeritus in the biostatistics branch of the NCI. He's shown here on the top left. The Tyrer-Cuzick model, or the IBIS model, includes a more detailed family history and hormonal factors and is widely used for determining eligibility for supplemental MRI screening. And we use this in our clinical practice at Cornell. And I couldn't really find much on who Tyrer was, but the Cuzick in the IBIS model refers to Dr. Jack Cuzick, who is a biostatistician and epidemiologist at the Queen Mary University of London. He also apparently pioneered the use of HPV testing for cervical cancer and was involved in discovering the preventative benefits of tamoxifen. So this man has made major contributions to women's health. So thank you and cheers to him. A third model to consider is the breast and ovarian analysis of disease incident and cancer estimation algorithm. The acronym is showed here, which is a statistical model that calculates an individual's lifetime and future risk of developing breast and ovarian cancer. And CanRisk is the web-based software platform that healthcare professionals can use to apply this model and calculate these personalized risk scores. So while these models have been hugely valuable, where we are now is that they rely primarily, as I've said, on clinical and family history data. Traditional models have several important strengths. They're extensively validated, they're relatively easy to implement, and they really provide a standardized framework for now for risk estimation. However, they do have their limitations, including, I would say, number one, their ability to discriminate risk at more of an individual patient level. Number two, many models were developed in primarily white populations and may not perform equally well across diverse patient populations. And number three, most traditional models are not yet fully incorporating imaging-derived information, which we hope and are seeing may contain important biologic signals related to future breast cancer development. So as breast imagers and those in the field, we're probably very familiar with breast density, illustrated on the top of the slide, ranging from fatty on screen left to extremely dense. So dense breast tissue is both an independent risk factor for breast cancer and a cause of reduced mammographic sensitivity. Specifically, women with extremely dense breasts have a substantially higher risk of breast cancer compared with women with predominantly fatty breasts. And so because of this dual effect, density has been incorporated into many contemporary in development risk models. And more recently, automated volumetric density measures have been developed and are in use in many places. We're not using them yet in clinical practice at Cornell, but you can imagine that they potentially provide a more reproducible and quantitative assessment than subjective visual BI-RADS categorization. And so incorporation of that into future risk models would also potentially be of value. Beyond breast density, there's a growing interest in extracting additional risk information directly from screening mammograms. Features such as parenchymal tissue, texture, tissue complexity, and radiomic signatures may really show us biologic characteristics associated with future breast cancer development. And several encouraging studies have demonstrated that these imaging biomarkers may improve risk prediction beyond density alone. And importantly, I would say, as a clinician focused, these approaches utilize images we're already obtaining as part of routine screening, making them potentially scalable for widespread clinical implementation. Artificial intelligence clearly represents one of the most exciting developments in this field. Deep learning models can analyze screening mammograms and identify subtle imaging patterns that may not be perceptible to the human eye. Multiple studies are showing that AI-based models can predict future breast cancer risk and in some cases, surprisingly, outperform the traditional clinical risk models. And I would say these systems really offer the possibility of more dynamic, highly personalized risk assessment. Significant challenges remain, including external validation, model transparency, generalizability, and of course, ensuring equitable performance across diverse patient populations. The next question that comes to mind, I would say, is how risk prediction, of course, can be translated into clinical practice. Risk stratified screening approaches may hopefully allow higher risk women to receive supplemental MRI or contrast enhanced imaging, which we're already doing, and then with lower risk women, hopefully avoiding unnecessary testing. Risk assessment can also identify candidates for potential chemoprevention or genetic counseling. And importantly, I would say successful implementation requires multidisciplinary collaboration among radiologists, primary care physicians, genetic counselors, sometimes medical oncologists, and of course, patients themselves. Looking ahead, I would say that the most powerful future models will probably be multimodal. Rather than relying on a single data source, future risk prediction systems will hopefully integrate not only clinical factors, family history, better genetics, breast imaging biomarkers, and AI-derived features, so multimodal. And prospective validation studies will, of course, be essential to demonstrate improved patient outcomes. We're not just trying to make better risk prediction models. Ultimately, the goal is to have better patient outcomes. And additionally, explainability, fairness, and transparency are very important as we move these models into, hopefully, clinical practice. To conclude, I would say breast cancer risk prediction is rapidly evolving from a traditional population-based models, hopefully to more personalized approaches. And I would say I think breast imaging is playing, of course, an increasingly important role through density assessment, imaging biomarkers, radiomics, and AI. I would hypothesize that breast imagers are likely to be central participants in implementing risk stratified screening and prevention strategies in the coming years in conjunction working with a multidisciplinary group. And I would say for me, one of the most interesting questions facing our field is whether future mammograms will serve not only as a cancer detection tool, but also as a comprehensive biomarker for predicting an individual's future breast cancer risk. And I think we may be hopefully entering an era where every screening mammogram becomes both a diagnostic and a prognostic examination. So with that concluding thought, I'd like to pass the virtual baton to my co-panelists. So thank you.
Thank you so much. I think that did a great job of getting all the general hitting all the key points, right? Where it's been, where it is now, where it's going, kind of what do we need to be on the lookout for. And I think you're still sharing your screen as well, but you can. So I mean, I have a question to get us going.
Yeah.
And before this, actually, before we started the webinar, Shadi and I were remembering our days back from PhD when we first met, and our research kind of overlapped in the breast cancer risk assessment space. And then somehow we both ended up at Cornell University. So maybe this is a question for Dr. Arleo or Shadi too. So what do you see as the biggest limitations of how breast cancer risk is assessed today, either maybe clinical or from more of the research epidemiology space? And, either based from the research or from your own experience, what are where's the greatest opportunities for improvement, whether that's on clinical care or maybe there's more on the research side?
Yeah, that's a great question. I would say as a general overlying concept, I feel like we're operating currently more on a population or group level versus individual level. I like that dichotomy, individual versus group. The Tyrer-Cuzick and the Yale model have obviously been hugely influential in our clinical practice, and but right now they're just, I'll put that in quotations, based on the clinical information, family history, reproductive history, all of which is so important. But I think that in the future, hopefully, we're going to have, as I was alluding to, imaging, biomarkers, AI-derived factors, hopefully better genetics, all incorporated as well. So I think in the future, these models are not going to be replaced, but rather that they're going to be built upon or added to make a more individual rather than population. We can think about risk in populations that, patients with BRCA1, BRCA2, CHEK2, first degree family history, but what about the patient who's immediately, sitting in front of me? I think we're going to do better at that level, hopefully going forward. Shadi, what do you think?
Yeah, I think also in terms of limitation of the these traditional risk score, I think in terms of research, we will see over and over papers coming up that shows that the prediction of these models are not doing very well, but we actually see them that they are also used in the clinical practice. And I think a great opportunity is using these image-based risk prediction models, that they are not fully rely on the remembering, for example, when was your first menstrual cycle, how many children, family history of breast cancer. So kind of questionnaire-based risk assessment models are, I think they are also more time consuming, but also not very accurate. And also, so I think the great opportunity is that we have these AI models, and we actually see some of the models that has been developed and validated. Currently, they perform pretty well, and they were also validated in different population across the world, and it has really good AUC, at least as compared to Weill and Tyrer-Cuzick. And I think it's also opened a door for prevention, for example, cancer prevention and early detection. I would also say these models are not only can be used for prediction, we can also discuss if they can be used as a detection for a better detection if
Yeah.
it is like 2 years or 5 years.
Yeah, I guess I have one follow-up question too is there a difference between these different models and looking at lifetime risk versus short-term risk? And like, what are the advantages? And are they going to be complementary in the future? Kind of what do you see that leading towards?
Yeah, I can answer this because this is also something that is very interesting in terms of like lifetime risk versus 10-year risk. I would say these models are not performing very well, and this is also shown by previous literature that lifetime risk are less predictive as the ones that actually like 5 to 10 year. So I think maybe that's also true for image-based risk prediction models, that lifetime risk is a very general kind of aspects, but they perform much better 5-year to 10-year. And then when it would come to 2-year, I feel like it's more detection than prediction.
Yeah, it's interesting because what I was thinking of is, the ACR stratification into high risk versus, not high risk or intermediate to low risk is based on, if a patient based on multiple factors that we have to date is calculated to have a 20% or greater lifetime risk of developing breast cancer, then they're considered high risk. Then they, qualify for supplemental screening with breast MRI. Obviously, we're expanding which patients are getting MRI, also incorporating particularly Cornell ancillary screening just for women just on the basis of dense breasts. However, traditionally, the ACR has used the lifetime of 20% or greater to determine high risk and thus MRI recommendation. So it's interesting. I feel like for patients, a 5 or 10-year risk would be a much more compelling number to present them with in terms of taking action versus like a more amorphous, lifetime risk.
Mm-hmm.
I really appreciate both these answers, and I'm learning so much from my co-panelists here. And you're both kind of talking around what I'm thinking about is a big challenge and also opportunity is how we're thinking about risk at a group versus subgroup versus individual level.
Yeah.
If we have a few factors that we know flag people for high risk and everybody else is other, what do people look like in the availability of that data? Not everybody has access to family history. They might, for various reasons, not have been able to collect biopsy data, or they might not be able to really easily come in for a mammogram. And so there are systems of inequity at play in even the things that we are clear about how we do and put into practice. And I'm thinking about a challenge and opportunity there is how we operationalize that risk assessment before, throughout, and beyond measurement, not just the scans and the speaking to the patient, but what is happening contextually and in that person's life that makes the difference between them being in the office or not. Because that is the major gateway that a lot of people just aren't going through, and then they never get to the point of risk assessment. If the ongoing risk assessment through an AI tool requires repeat measures, who are we not including in those data or in that opportunity for benefit? And what do the treatment outcomes look like in the long term? So in terms of research, if you have focused on epidemiology, you might know the name Walter Willett, sort of the father of modern epidemiology, and his famous quote is, "We measure what we value, and we value what we measure." And we don't collect data in this context. We're not collecting data just because we're curious. We're collecting data because we want it to be practically useful for actually improving and saving lives. And not all data are created equally. There are different ways to ask questions, different ways to make the statistical analysis more relevant, more valid, more clean, and collect data that actually relate to how is this knowledge put into practice in the real setting, not just what does it mean in the abstract. Yeah, it's an opportunity for intentional versus reactive data collection. And when it comes to the AI, potential AI models that we're building that inform breast cancer risk prediction, AI models are built on the data that feed them. And so if the people that have the most money are the ones that are most likely to have access and ability to get mammograms most often, those are predominantly going to be white women. And so the risk models will then become more and more far apart from the population as a whole and specific subgroups in particular. Like breast density does not look the same across racial and ethnic groups. The average is different, the peaks are different. And we have to be thinking about that, because if you're planning for the average patient, you're planning for none of your patients.
Yeah. And I think you and I have had a long conversation specifically around the first time we met, first or second time we met. And I think this goes nicely into the next question I was going to ask. So kind of, I think this is a good transition, is, as our ability to identify women at elevated risk improves, what responsibilities do we have either as clinicians, healthcare systems, researchers? I think Julia got at pretty well, but what responsibilities do we have to ensure that the information leads to meaningful action rather than simply more data or more AI output? So I guess how do we make this actionable and in a meaningful way?
I can answer from like a clinical perspective, maybe pass the baton on, I think you hit the nail on the head just in asking the question itself, just that it's important to recognize that just, prediction without action is really of little clinical value. So our goal is not to just make better risk prediction models, but actually to translate that into better patient outcomes. It's kind of obviously we want to stay it, but it's worth staying. And then, Julia, as you were talking about, as we do this, it has to be, applicable and available for all patient populations. And you make such a good point. It's like scary when you think about it, that the AI models are training on themselves. And if what you're feeding in is a limited patient population, it's like a vicious cycle. And then also to further answer your question, Kendra, I would say that, the other responsibility is, as we've been alluding to, if we're identifying better and better predicting women of higher risk, then we also we can't just predict it. We have to have some clear pathway, clear, actionable management recommendations, whether it be supplemental screening with MRI or referral to genetic counseling or consideration for chemo prevention. We need clear, actionable pathways.
Yeah, I think from the research point of view, it's also very important to make sure that some of these risk prediction models, they say also they were validated in, for example, at Karolinska Hospital, it's in Sweden, in Chang'an Memorial Hospital in Taiwan. But we also have to look at whether they were validated in general population or was it only a single institution type of validation? Because it could be that this validation at Karolinska Hospital is only one hospital, or a Memorial Chang'an Hospital is only one hospital. So sometimes it's very important to ask question whether the model can be validated across country, where the mammogram coming from different vendors. Some vendors are, outdated. Some of them are very, a modern one that's also impact these risk prediction models. Are they like, for example, new model of Hologic, or whether they are the new model of Philips and Siemens? So it's very important that do kind of like a real world data analysis and see all these mammograms coming from across a country. And sometimes we will see that this prediction or the AUC is lower than what actually been done in single institution type of a study. So in that sense, it's also very important to look at from the research side and the validation side.
That's a good point. And so, Shadi, I know you mentioned earlier, like there's been higher AUC compared to like the traditional lifestyle risk models, and there's some advantages there. So I guess what are the biggest challenges to actually integrating this more personalized risk assessment into routine clinical practice, right? And how can healthcare systems overcome them? Yeah, that's your question, I think.
I mean, I'm so grateful to be on this panel, and I'm
Yeah.
so grateful that you guys are doing, research, at the different, levels, because like sitting here reading studies, seeing patients, like you can only focus on one thing, and I can't wait for it to be integrated into clinical practice. And I think to answer your question in one word, it would be workflow, because science is making like incredible advances, but workflow is an adjacent issue. Like, how are we going to automatically, incorporate this into seeing patients, into the electronic medical record, have it spitting out, consistent recommendations? How do we make sure, all the doctors involved in a patient's care, the radiologist, the surgeon, the medical oncologist are all working with the same guidelines and data? And obviously, if it's better integrated into clinical practice, then it's going to get better use, and then we really are going to lead to better patient outcomes. So I think it's all about workflow integration. I don't know how to do that, but I'm glad there are other people thinking about it.
And Julia, you had mentioned, maybe there's some inequalities at play as well. Do you have any thoughts about like how healthcare systems could address that? Or
Yeah, I do. And I'm trying to think about how to be concise about
Yeah.
that. I want to say the word responsibilities is important, and it's also heavy. And so I want to acknowledge that the clinicians working with patients are already doing such incredible work and working so hard often with very little time and resources. And so I'm hesitant to put anything out there that's like, you also must be responsible for doing X, Y, and Z. So I really appreciate Elizabeth bringing up the workflow idea. As we're coming up with these transformative ideas, is it actually something that works for the people that need to operate it in their lives without slowing down their essential work? Thinking about the clinician and the clinical team as humans, and then also thinking about the patient and their human experience. I have many layers of privilege that I walk into the doctor's office with. And I've often gotten asked, so do you have a boyfriend, or what's your husband's name, while my legs are in the stirrups? And then I say, actually, I have a wife. And that's not really where you want to be coming out. And that's also a distraction for the rest of the appointment. And so encouraging clinicians to think about the breadth of their community, thinking about where their assumptions are and how they might question them, and how they might make patients not just feel welcome and seen, but encouraged to return. Because you can flag high risk with the most accuracy in the world, and it means nothing if that patient isn't coming back, if that patient doesn't see where they can go for support, or where they can get language that they understand and that they feel safe in that environment. So yeah, really thinking about this isn't just, I have a patient, here's your risk, and then this is what people with this level of risk do. It's, what does this mean for you as an individual in your life? Yeah, that feeling makes a big difference in accessing that care, I think.
I think that I thank you for sharing that. I think it's like just so spot on, and how you convey information to a patient or query them makes all the difference. And over the past couple of years, I get asked like, "Oh, are you worried that AI is going to take over your job? You'll be out of your job, etc." And I'm always like, "Look, I'll take all the help I can get, and if all the models we're talking about or integration and workflow and all that gives me, hopefully, it, among other things, more time to sit with and speak with a patient at a human level, like, thank you. That's a huge add too. That is a huge add. And not scaring people off also with this risk information. Like, you could scare someone off, they could be, paralyzed with the fear.
Right.
But also, sharing and delivering the news is like, what do you want to do? This risk tolerance for risk varies. It's very personal, and so there can be recommendations, but also a process. Of course, it should be a process of shared decision making between the patient and her, clinical team.
This is, I think, also a moment where nuanced language can be really impactful. So in epidemiology, risk is what we think could maybe happen. Risk and reality are two different things.
Mm-hmm.
And it's not a diagnosis, it's not a future, it is everybody has a set of variables that might make something more or less likely. And so we keep an eye on this in this way. But helping people not get caught in that sort of like, what is an ecological fallacy. Fair-skinned, blue-eyed people are more likely to get skin cancer diagnoses than dark-skinned, dark-eyed people. That doesn't mean that as a fair-skinned, blue-eyed person, I will get skin cancer and that a dark-skinned, dark-eyed person won't get skin cancer. It's just part of an overall profile, part of the complexity of everybody's individual story. Sort of maybe unpacking some of the assumptions that they might have around certain words.
Yeah, I think very important point about language as well and how you communicate the risk, because for breast density notification, we have it now in the US, but in Europe we didn't have this. And if you want to know about your breast density, you can actually ask, but they are not actually sending any letters or anything unless you're really high in density. Then they will send you for supplemental screening. And the reason is that there is no resources kind of like planned after if you have high density to go for supplemental screening or no. So it's kind of like not planned, and they feel like if they say that you have high density, and high density means high risk of breast cancer by 4 to 6 times, then it actually provides a lot of like stress and anxiety to women, and maybe it's unnecessary. Whereas here that we have this insurances that they actually willing to cover, and hopefully they cover, at least in New York City. I think they are covering, right?
Well, that I was going to say that's a very important point. Like let's think about it. I'm glad you brought up the insurance issue. I'm not entirely current on where we are today in New York State, but the catch-22 situation was when it originally came out. A lot of the research on breast density and the importance of supplemental screening came out of Connecticut, and they were one of the few states where so then all these mandatory breast density notification laws for the majority of states in the US, there's a federal bill up. I don't think it's been passed at the federal level. So you have to notify, and you suggest supplemental screening might be of value. And yet Connecticut, certainly in the beginning, was one of the only states that was actually paying for the supplemental screening. So talk about creating anxiety. Hey, you have this risk, you should be getting this, but we're not going to pay for it. I mean,
Yeah.
Or even, why? And I don't know this. Like, is it, maybe it's harder to see breast cancer in this kind of you have more, your breasts are bad, yeah, and that just sort of relates to, feeds into overall trust with the healthcare system and trusting your providers as people that care about you.
Yes. So I think my last question, which I've already got comments from some of you that it's hard to answer this in one thing, but if we have this conversation again, say in 5 years, or if you want to reframe it for 1 year or 10 year, that's fine too. What changes do you hope we'll see in breast cancer risk assessment and patient care?
I'll maybe start again from the clinical perspective.
Sure.
I would say, my top two would be or three would be, you know, validated multimodal risk prediction integrated into routine clinical practice. That's like number one. And that I hope that it will include screening mammography, pulling out the imaging biomarkers, so the screens that we're performing are not only, you know, diagnostic, but also predictive of risk, and doing a better job for all patient populations. I mean, the list is like kind of a very long list. I'll keep it to those three for now.
Thank you. Shadi?
Yeah. Yeah, I think I completely agree with Elizabeth on the points, and I think from now it's like also validated in using different population as well. So we are kind of like certain that this model is developed and validated and can be used, for example, for African American women with different AUC as you see for Hispanic and white women. So I mean, it's sometimes when you talk to engineers, it's a little bit different, that they are very obsessed with the AUC that is higher than this model, but it's like in terms of meaning and clinical meaning and practices, what actually it means. And that's why I'm always interested to read both papers that are more like engineer type of papers, and also like a clinical ones that you actually have idea about like the clinical usability of the model.
What they said.
Yeah.
I love alliteration, especially when it's accidental, but what came to mind was investigation and innovation with intention. You know, if we are building something to solve a problem, how are we keeping in mind the people that suffer from that problem, the people that are trying to diagnose and address that problem, the context that they live and work? How are we doing this are we doing this in a way that is actually functionally beneficial in this system, especially understanding that a lot of people are strapped for resources and time? How can we jump in to the situation that's happening with real impact, not just in theory?
I want to add
a lot of conversation. Yeah, go ahead, Shadi.
Sorry, I want to also add one more thing. So I also am very interested on like risk prediction models that are cancer specific types. So not only is like predicting breast cancer, but going to like lobular breast cancer, inflammatory breast cancer that are rare, aggressive, common in young women. So kind of like risk prediction models that are specific to subtype breast cancers.
Yeah,
Hopefully
that's
it's
super important to be able to identify women who should start screening earlier, because if you don't know that, then you're going to present with something as palpable and at a later stage and a worse prognosis, and you may not even. Yeah, I share that.
And from a population data perspective, if you separate that group from the people that get breast cancer later on in life, that might really clarify distinct risk models that make it easier for us to identify people in both groups, rather than muddling risk across the two when they might be really clinically different.
Yeah. Did you have was integration on your list of I's? I'd like a good alliteration.
No. Okay, we'll add that. Investigation, innovation, and integration with intention.
That is
We're on fire.
I think that's a good way to end. So yeah, so I want to thank the Dr. Arleo for giving the presentation, and also our two additional panelists, Shadi and Julia. Thank you so much for bringing your perspectives to this really important topic that we're all, I think, pretty passionate about. So yes, so thank you so much. And then if there's any questions, we're happy to also follow up through email. So feel free to reach out, and then I can help facilitate any of those conversations as well.
Thank you
Great
so much.
conversation. Thank you so much.
Thank you.
Thank you.
Bye-bye.